I was 6 months junior to Shreyas.
Okay.
No, one year. Yeah, one year.
Ma'am, we are in live.
Okay, right. A very good evening to one and all of you to our uh, um, Eye Foundation Eye Edu webinar. And this time we have a very interesting topic. I'm sure something which all of us who don't know much about it should get abreast to. This is time it's on ocular aesthetics innovations in periocular rejuvenation. We are truly lucky to have the best and the richest of expert panel. We have with us Dr. Milind Naik, who's a consultant ophthalmic plastic surgery and facial aesthetics, and he's a super expert in the cosmetic and reconstructive surgery of eyelids and face, besides all else that he knows. We are lucky to have with us Dr. Mopia Goswami, who is a consultant ophthalmic plastics, oncology, and lacrimal surgery and facial aesthetics from Narayan Nethralaya, Bangalore. Thanks a lot, both of you, for joining us. And we are very lucky to have Dr. Shubhra Goel, and who's a consultant oculoplasty and facial aesthetics from Apollo Health City, Hyderabad. Thanks a lot, Dr. Shubhra, for being with us. Moderating with me is Dr. Vidya, who's a senior consultant oculoplasty and ocular oncology from our Eye Foundation group of hospitals based at Coimbatore. And of course, Lakshmi Shankar, who is recently joined us as consultant orbit and oculoplasty, Coimbatore branch. So without wasting time, we'll go on to our first speaker, our young, attractive Dr. Prerna Tahilayani, who's a consultant ophthalmic plastic surgeon and ocular oncologist from Mumbai Eye Plastic Surgery. And she's going to take us on an interesting topic, laser therapy for periocular skin. On to you, Dr. Prerna.
Thank you so much for this kind introduction. So I'll be talking about something that is relatively new, if you ask me, even for oculoplastic surgeons. And I give the credit for knowing a little bit about periocular lasers through my background. I come from a background of dermatologist. And lasers in aesthetic industry is a multi-million dollar industry. And why should ophthalmologists stay behind? When you look at ophthalmologists, we are the king of lasers. You have multiple books about each and every micron on the eye, which can be treated with some kind of laser. But surprisingly and paradoxically, nobody talks about the largest part of the eye or the ophthalmic unit, which is the eyelid skin. So why should that be left behind? So when we look at lasers, we are all used to energy-based devices in oculoplasty like the radio frequency or the cautery. But laser is something which is akin to, an army force. So it's a formidable force. It's an energy which is collimated light. It's in phase and it's single color or monochromatic. Now, patients like these are often seen in ophthalmology OPDs where we are counseled day in and day out through our residency days that, you should talk about chances of glaucoma or choroidal checkups or annual screenings. But a 40-year-old lady, when she comes into the clinic, she doesn't know about these possibilities. What bothers her more is the pigmentation. So she wants to know if anything can be done for it. And yes, of course, there is a laser that can reduce this pigmentation in nevus of Otan. Now, in my armamentarium, I commonly use two lasers, the ablative or the carbon dioxide laser and the non-ablative or the pigment, the Q-switch laser. So, because in the interest of time, I'll only be covering the carbon dioxide laser. Now, carbon dioxide lasers now are all fractional or ultra pulse. What I mean by ultra pulse is that in order to ensure safety, the laser is shot for such a short time that it is lesser than the thermal relaxation time of the target tissue. And the target tissue in carbon dioxide laser is water. So, as such, it is not selective for photothermolysis, but it has a fairly constant target tissue of water. So the laser is focused in these micro beams, which causes ablation and vaporization of the epidermis, and it is surrounded by intervening normal skin, where the collagen shrinks and causes new collagen formation. Before we start using lasers, it is very important to know about some principles of ocular safety or even clinic safety, and you have to have very trained personnel handling it. For the eye, it is important because the eye is like a focusing organ, and any kind of laser that you put, either the pigment laser will get focused on the macula, or the eye is rich in water, so the carbon dioxide laser could have untoward side effects on the eye. So you have to know about certain precautions that have to be taken. What I use in my practice is an Italian machine. It's a Deca laser. This is one of the gold standards for carbon dioxide laser. And how this works is I'll just show you a short video. So this is how the laser fires. This is done under topical anesthesia, which means numbing cream. You can see that the laser beam is focused and you can immediately see the dermis and the epidermis contracting. So where it works, predominantly I use it most often as an adjunct to blepharoplasty for some kind of wrinkles that are left behind after surgery, for scar revisions or scar rejuvenations, for festoons or crepey skin. And now I've also started using the spot focused beam for ablation of things where you don't have to do surgery anymore. So going to that, this is one of my patients where I've done a lower eyelid and upper eyelid blepharoplasty. But if you look at his malar mound and the lower lid skin quality, even after a pinch blepharoplasty, the laser is going to give you that extra brownie point to remove some of those rhytids. This is another lady who walked in and she was very disdainful about how her lower eyelids looked. And I knew surgery is not going to help her lower eyelid. So, what I promised her was upper eyelid or ptosis surgery for rejuvenation. And we combined it with a lower eyelid carbon dioxide laser. This is how it looks on day one after the laser is shot. And this is a 1.5 month result where you see that there is some reduction in the lower eyelid wrinkles as well. So, what do you expect after laser? What do you have to counsel to the patient? You have to expect some kind of swelling, some kind of erythema. The scabs usually you can get rid of them in a week's time. But in very tricky patients, there could be some edema up to 6 weeks as well. And what you have to do for immediate aftercare is adequate amount of ice compresses, avoid sun exposure for 3 to 4 days, and some healing ointments for the epidermis to get better. Now, in thermal burns, because the surrounding tissue has slower healing or delayed healing, it has to be used a little conservatively. But this is a promising result in a patient who had hemifacial, hemiperiocular, as well as cheek thermal burns in childhood. And this is after pigment and Q-switch NDI laser, where you see that the depth of the scars have also reduced, or the shoulders of the scars have reduced. Again, for scar reduction, it is a very important tool in our armamentarium and works like magic. So this is a verrucous epidermal nevus. It is a part of spectrum where even ILVEN is at the other end, and sometimes we would want to use radiofrequency or surgery to remove them. But one shot of carbon dioxide laser after 1 month, you have to trace where you have taken it out from. So it's very conservative. It's an OPD based procedure. And this is a nevus excision, which maybe I would have done in my fellowship surgically. I would have removed it, but this is 2 shots of carbon dioxide laser, and the patient has healed well at 1 month. Having said all this, there are some contraindications where you have to be careful. If the patient has inflamed skin, active acne, active infection, or if they have vitiligo and there is Keebnerization, then these are not good ideal candidates for this using the laser. Patients who've undergone severe burns or have autoimmune or immune mediated diseases where there is delayed healing, you should avoid this procedure and be conservative in patients who are on prophylaxis for herpetic eye disease or herpetic skin disease because you might reactivate. Now, coming to the Indian skin, I should highlight the role of a test patch because you do not want untoward edema and you don't want the patient to be left with a bad experience. So, sometimes it's good to test a very small patch of the skin wrinkles or the fluid that you're addressing. And if the patient does well, then well go ahead and treat the entire area around the eye. So, like I said, these are once you've overcome the part where you've done a test patch, then these are candidates who are ideal where you have crepey skin or malar fluid. Then they will do very well with laser resurfacing with carbon dioxide laser. So to summarize, the ideal cases are Fitzpatrick grade 1 to 3, which is the less pigmented skin kind. And when they don't have any history of hyperpigmentation or post-inflammatory hyperpigmentation or any adverse events with
Okay,
prior
one
skin
minute more.
treatments, these are good patients. And patients who have realistic expectations and timelines. Thank you.
Oh, that was a wonderful talk. At least for me, it was so much of learning. Um, Then you, in the very beginning of your talk, you said there are these ablative lasers and non-ablative lasers. So is it like one works for a particular skin better than the other or something like that?
So they work for very different indications. The carbon dioxide laser was actually invented by Mr. Patel in US, and it was a surgical tool. It was basically used for incisions and ablations and even to perform blepharoplasties. And for non-ablative lasers are predominantly the Q-switched NDI pigment laser. So they have a different chromophore, which is the melanin pigment in the skin. So they have completely different indications. The carbon dioxide is more for taking care of pre-malignant small growths on the skin or the eyelid. And in the fractional mode, they work well for rejuvenation or reduction of rhytids, reduction of fluid, and reduction of festoons. Whereas the Q-switch NDAG is for pigmentation, like dark circles or nevus of ota. And I'm also using it now for nevus flemmis. There are different parameters that we need to study.
Is there something which you would use for a younger skin or some different kind of laser for the older skin?
So, like I said, the laser, to start operating the laser, it's like a formidable force. So it's like a whole group of army. So you have to have in-depth knowledge of physics, and the machine may be the same, but there are so many modes and parameters, and there are different probes. So some probes have a smaller spot size, a focusing lens. So all of this is very important. Like you have to know the physics, and you have to know what energy, what parameters, what fluence to use for a particular kind of indication.
Just a quick question, Dr. Prerna. So,
Yeah.
Ibrium, this YAG you mean is the YAG laser is what you said is for the pigmentation, whereas
The
the
Q
carbon
switch
dioxide.
NDI. Yeah, yeah.
Okay. So YAG you don't use. So the skin tightening occurs even with the carbon dioxide, which you just showed us now.
So skin tightening predominantly occurs with the carbon dioxide laser. And
Okay.
in the US, they use more of the erbium YAG laser. The carbon dioxide laser has a wavelength of 10,600 nanometers. The erbium YAG is lower in the 2000s. But the advantage of carbon dioxide laser is that the depth of the dermis at which it goes, it causes selective photocoagulation. So there is no oozing, and it sort of coagulates the capillaries as well.
Okay. All right. And just a quick question. So when you do glyph, which has a fat and a fluid content, you would do the fat removal by surgery, and then after that you do the fluid with the laser, is it?
So, for ideal case scenarios, yes, not all patients with fluid are good candidates for carbon dioxide laser. For some of them, you may get away with a SOF lift. So, you have to really understand the profile and the expectations of the patient and then figure out what is to be done.
Dr. Milind and then Dr. Shubhra, would you all like to add something to what Prerna has said, something important for us to know on this issue before we move on to our next speaker?
Yeah, hi, Prerna. One question. Nice talk.
Thanks.
Would you modify your settings for the Indian patients? And when you refer to those settings, do you follow the guidelines of the Western literature, or do we have enough data from within our country?
So we have enough data, luckily, now from within our country. And the Western literature, the settings and the parameters will be a lot more aggressive for carbon dioxide, where you can obviously see the changes. If you look at social media, most of these videos are the Caucasian patients. But Indian skin unfortunately gets baked, and hyper or hypopigmentation is a known risk. So the lower parameters, lower fluence, and the density of the energy percentage wise less than 11%, that is what I would prefer for the Indian skin. So I would reduce the parameters, and like I said, doing a test patch works well for the patient as well as the doctor, because you've earned the confidence of the patient. If you don't go directly and aggressively treat them and cause untoward side effects, you might lose the patient forever.
Okay, on this.
Right. So,
Sorry, Milind, go ahead.
no, just wanted to highlight that this is an important point, that CO2 laser settings have to be much lower than what one would see in the typical Caucasian patient. Thanks, Prerna.
Thank you so much. Yeah.
And Shubhra, Dr. Shubhra.
Yeah, thank you, ma'am. Prerna, wonderful talk and a wonderful work as always. On the same note, what Melinda asked you and you've been presenting, do you prime your patient's skin before you actually take them for CO2 laser? Because most of the Indian skins are not primed, and we are dealing with Fitzpatrick 3 and 4, occasionally 2 and 3. Even if you set the settings to a lower module and you kind of titrate it for Indian patients, do you do that in your cases, or you just kind of go ahead with your settings and play around with it? Or another question is, do you play around with the combination of lasers because the CO2 is not the one fit for every patient, you know?
Correct, yeah. So I also do a lot of Q switch NDAC, but it wouldn't be possible to cover both of them in 6 minutes. These are the only two lasers that I deal with. So with respect to priming the skin, I don't particularly prime them, but there are definitely some cautious points. Like a lot of patients now do a lot of skincare themselves, so they have to stop using exfoliating products, and they have to stop using active vitamin C's and other products, at least 2 to 3 days before we schedule them for the procedure. And like I said, they should not be having any kind of active inflammation, which is ongoing, or infection on the skin. In fact, my last takeaway point had a patient who had come in for the CO2, but he had active verrucae all over. And I was like quick to pick it up and tell him that this is, we should reschedule this procedure today.
Yeah, so why I brought this is I think it's very important because everybody is looking for quick fixes, including
Hmm.
lasers, because the social media is all talking about quick lasers, variety of lasers, this can be done, that can be done. So I think as you have pointed out, the kind of laser, the type of laser, the parameters and the selection of patient is of paramount importance before we jump in. And as in any procedure, I think you need to understand the anatomy and the technology very well because there are too many lasers in the market. You don't know which one to pick up. So thank you, Prerna. Thank you, ma'am.
Thank you so
Thanks a
much.
lot. Thanks a lot, Prerna. We would have really loved to hear a lot more from you. We shall now go on to our next speaker, Dr. Priya Suresh. She's a very sincere, committed dermatologist and cosmetic expert from Coimbatore, who runs his works essentially in the Zia Clinic at her own hospital. And she is going to talk on dermatologist's guide to periocular Botox and fillers. On to you, Dr. Priya. Can you share your screen?
So, at the outset, I would like to thank Professor Dr. Chitra ma'am for giving me this opportunity. So, a dermatologist's guide to periocular Botox and fillers. So, we all know the periorbital features are the most scrutinized part of our face, and the periorbital region is one of the first to show the effects of aging. Orbicularis oculi muscle is the main muscle which is responsible for the crow's feet. And I would like to do some brushing up about the basics. So we know about the ligaments. The most important ligaments are the tear trough ligament. Then you have the zygomatic cutaneous ligament, the orbicularis retaining ligament, and the superior temporal ligament, as well as the fat pads, which makes us to feel young, to see youthful. So the fat pads are the superior orbital fat pad, you have the inferior orbital, then the lateral orbital fat pads. Now, what happens in aging? So, facial aging is marked by the atrophy of the bony skeleton, which is the most important thing which happens, which is the bone resorption, followed by the descent of the fat and the depletion of the malar fullness. As a result, we see there is a wider orbital aperture, the anterior projection is reduced, and the overall projection and concavity of the cheek is reduced, thereby leading to infraorbital hollowing as well as the mid-ptosis, mid-face ptosis, which we see. So as a result of the mid-face ptosis, we see some grooves, namely the nasojugular groove, which is present medially, where we call it as the tear trough. Then you have the palpebromalar groove and the mid-cheek groove. Now, this is uh, a slide which was taken from a paper, Understanding the Under Eye, where Dr. Nayak sir has mentioned about the hills and the valleys. So this is very, very important to decide whether the client we are going to inject or you're going to take for blepharoplasty. As you all know, it's just, I'm going to tell only for the understanding sake of the anatomy. So there are three hills, mainly the muscle, the ocular muscle, which is shown in the arrow as O, and then you have the tear trough, as well as the you have the lacrimal sac. So these are the hills which has been mentioned, and there are three hollows, namely the you have the infraorbital, the tear trough hollow, then you have the zygomatic hollow, and a malar mound which is present in it is represented as asterisk. Now what happens? Now you know there is a hollow which is created, which is called as a tear trough, and now we have to treat it. So before going inside the treatment part, we should know that the arterial supply is very, very important, as the facial artery gives its branches all over as the superior labial, then it gives the angular artery, followed by the ophthalmic artery, which is very, very important, as this area is the dangerous area. So care should be taken before injecting this place. What we follow as a dermatologist are the MD codes. It is called as the Mauricio Di Maio codes. So these are a series of predefined injection sites within each anatomical unit. For example, so the advantage of these MD codes are that you will have a precise area where to inject, which depth to inject, which amount of the product we should inject, and what product we should choose. These are things we can, they have given already a protocol, so we can follow that. So our work becomes simplified and less side effects. So the tear trough area can be divided into TT1, tear trough 2, and 3. The 3 is the medialmost part, TT2 is the lateral, and TT1 is the middle central inferior orbital area. Now coming to the 3-point tear trough reshape, you have the TT1, which is called the central, TT2, the lateral, and TT3. Let's go deeper inside it. According to the protocol, TT1 is the mid central infraorbital area where a volume of around 0.1 to 0.3 can be injected. Two products are recommended in this area. I would like to inject more of Volbella in this place. Being a beginner, this will help to actually the Volbella is a very good product. It pardons you if you make a mistake. Also, it spreads very nicely, and it spreads in all deeper planes and doesn't form lumps. That's the main advantage of Volbella. So cannula as well as injections both can be done in this area, and be wary of the infraorbital area artery in this area. That's the only thing, and it has to be injected as micro or aliquots. The second is TT2, which is the lateral part. So the lateral part actually is a relatively safe injection site. It can be used with cannula as well as injections. 0.2 is recommended with Volbella. Micro aliquots can be delivered in this site. Always it has to be injected at the level of the bone and not into the bone. Be wary of the lacrimal artery in the TT2 place. The third one is the TT3 area or the tear trough area 3, which is the most important thing. Unless you're an expert injector, it is better to avoid this place also. Here you have there is a higher alert for infraorbital foramen, the angular artery. So the ideal way of approach of a TT3 can be with the cannula. From the horizontal place, from the TT2, you can push towards the TT1, towards the TT3. You can push the product. That is one method. And the other method, after doing a lot of cases, You can do a nasojugular approach to TT3 also. Cannula is the safest way of injecting in this area. 0.1 to a max of 0.3 ml can be injected in this area. Again, crow's feet. If the crow's feet becomes a static instead of a dynamic lines, then fillers can be also opted in this area. So Volbella is the best injection which can be given here. Again, we have codes for it, which is 01, 02, and 03, which is in the central, lower, as well as the upper lateral periorbital area. Cannula is safer here. This is a relatively safer point which can be injected. O3, again, you have the lacrimal artery there, as is the gland. So care should be taken at the site of O3. So O1 is in the center, O2 is in the lower part, and O3 is in the upper part. So same way as we inject for the crow's feet with the Botox, it can be done with the fillers also. Complications, what we face, it can be an injected related, the techniques, the proper techniques has to be used, and it can be patient related. Sometimes medical history should be taken properly. The patient would have been on blood thinners. So those things we should ask them whether they are diabetic or hypertensive. And the product related ones, like a proper product should be used in the proper area. Early reactions, pain, ecchymosis, erythema, bruising, these things should be explained to the patient. Any allergic reactions may happen. And vascular compromise, vascular infarctions can also be seen. Migration of the filler can happen. And as late reactions more than 3 weeks, there can be nodules, dyspigmentation, and displacement of the hyaluronic acid filler, especially at the TT3 area. Now let's discuss about some case scenarios which we see. In Coimbatore, we see that the patients want some subtle changes. They don't want any more enhancements. So I'll go one by one regarding some special cases which I've seen. So he's a 32-year-old gentleman who came with skin laxity only in this area. And he had a little bit of tear trough also. Since he was only 32 with crow's feet. So Botox was suggested. Usually I go step by step. So Botox was suggested for the skin. And this was before and after. And he was okay with it. So I have suggested him the Volbella injection later. So you can see the crow's feet has gone. And this is better. If the client is okay, we are also okay. So this was my first patient with tear trough injections. 0.1 ml was injected on TT1 and 2 places. TT3, I was very scared, so I didn't do anything. So you can see that the before and the after pictures where TT3 has not been touched. So one patient, he's an atopic with the hyperpigmentation, with thickening of the under eye because of repeated rubbing. He also had a periorbital hollow for which Volbella was suggested. He was okay, and now we are continuing him with periocular peels for him. There's another one patient where she had a malar fat pad also, the SOOF projections. So nasojugular approach was done with Volbella injections of 1 ml, 0.5 on each side. She needs to be injected more in subsequent sessions. This one ma'am, she was 55-year-old. She came for the total changeover for her son's wedding. So first we corrected her with fillers and Botox. Mid-face was corrected for her first. So there's a lot of changes because in 40 plus we would expect more of mid-face.
Doctor, time is over.
Yeah, I'm going to finish, ma'am. Yeah, mid-face ptosis. So followed by the Volbella injection. So always when you see a 50-year-old persons, you have to do the mid-face treatment as like a construction followed by the periorbital rejuvenation. One ma'am again Only CK1 was injected, the mid cheek was injected without any changes. She had a nasojugular groove. She was only 23-year-old, where only periorbital area was injected. TT3, TT2, and TT1 was injected for her. So take home message, assess the face as a whole. If only under eye is involved, then plan accordingly. Always undercorrect the periocular region. You can do it later on. Medical history is very, very important. Inject with utmost care. Post aspiration is must. And cannula is the safest approach in the periocular area. And always explain the client of the possible complications. Thank you.
That was a wonderful talk, Priya. I mean, I wouldn't have expected anything less than that. And I've known her, and I know there's a huge amount of compassion and concern the way she deals with her patients. So instead of me asking questions, Dr. Milind and Dr. Shubhra, would you like to take questions with her?
I think Mopia is an expert in
Yes,
Botox.
Yes, Dr. Mopia, would you want to?
Yes, ma'am.
Her presentation was good
Yeah.
and points were nice and no particular questions. She presented well.
No, when it comes to fillers, would
Yes,
you
ma'am.
believe that you give one filler only, or you call them for subsequent sittings and give
Yes,
them?
ma'am.
We
Usually I do it as a building step like thing. So I do with the first a minimal amount followed by stepping up for them.
Okay.
I have
And
a question, Dr. Priya, for you. Wonderful presentation. I think MD codes is what you have advocated as a dermatologist. Personally, I don't follow MD codes to that extent because it kind of makes you very stereotypical in your mind how to treat a face, but it's a good landing point and a starting point. So, any particular reason why you do only Volbella under eyes, or do you prefer some other fillers as well?
Volbella, the product is fluid like. So it is the best thing to be without any lumps. If we go for a thicker product, definitely we'll land with Tyndall effect. That's what I see. So better to go with Volbella. And if you're confident enough, at the later stage, you can change your filler.
Okay, so basically your take home is that as a beginner, it's good to start with Volbella.
Yes, ma'am.
Because
Yes.
of because of the cohesivity and
The G prime.
the G prime of it. But for the knowledge of the audience, and I think Milind and Mopia and others can add on to it, is that in my experience personally, I'm not a big Volvilla fan because it kind of fades away very fast and it gives you a very great instant result, but over a period of time, patients are not that happy. And I think you need something more heavier but not firmer product. And I think I have shifted. I've tried with Ultra Pluses and with Volbillas and with Restylane Classics, sometimes a combination into the periorbital area laterally and doing tear trough little differently because the periocular area in Indian patients is very complex. It's unlike the Caucasian patients. So most of us have very prominent cheekbones with the malar hyperplasia here. And you may have not a very typical, zone to fill up these areas. So I think just for the knowledge of the audience is that you can play around with other products. It's not necessary to just stick to Volbella because it is one of the products which can be used for under eyes. And I have a lot of people on the panel who do under eyes and periocular area as well. And as far as the complications are concerned, have you seen any major complications in your hands or any cases referred to you with the tear trough or periorbital area filler injections?
No, ma'am.
Yeah.
If you do it in a proper way, you won't land with complications and with a proper anatomy.
Yeah. So I think
That's why I recommended Volbella so that it will be okay. But if you want to use a thicker product, definitely Restylane is also super. And if you're very pro in it, you can go for Voluma also in that area.
yeah,
And Dr. Shubhra, can you add on what she mentioned about those 3 injections for the tear trough? She mentioned 3 points. Do you follow that?
The T1, TT1, TT2, TT3, O1, O2, O3, if you really look at it, it is just exactly the same area which you will follow, because you need to understand the length and breadth of the tear trough. You need to understand the skin texture of a patient, and you also need to understand if there is an associated malar hyperplasia if you really want to augment the OG curve, right? You want to bring it forward. So, as I said, it's a good starting point to stick to the basics and start with the basic and a very simple filler. Coming to Tyndall effect, I think Tyndall effect is not that much related to the product, but where do you inject, at what depth, and how
Yeah,
much
superficially also.
injected. So it's around 0.2 to 0.3 mil, which you need each side, even in worst of the dark, tear trough, grade 3 and grade 4, which I'm talking about. So I think that's how we titrate, and it is a complex area. But I just want to say the tear trough is not so difficult to inject, especially for ophthalmologists. And we urge all our ophthalmology friends to start practicing it and trying it out. And to have a complication in a tear trough is much lesser than nasolabials or pyriform fossas or the other areas on the face. You really have to be a butcher or unlucky to really cause a vascular compromise in tear trough.
Now, how long does this effect last if they're working in that particular the topic which you're talking now? Would that change which you provide them last for 3 months, 6 months, or a year at least?
It's for a year, ma'am. It's for a year.
Ma'am, I'm going to talk about that in addictions. Wait for it.
Yes, I wait for it. Yes, sure.
And Dr. Shubhra, last question. Do you prefer cannula or needle for tear trough?
It's for Priya or for me?
I mean, for Dr. Shubhra, I was asking.
Sorry. No, I'm a needle person. I'm trained needle. I'm not a cannula person because I want to feel my tissue. I want to feel where the product is going, and especially the periocular is very sensitive. But people who are trained in cannula is perfectly fine. I prefer needle personally.
Thank you.
Thank you very much, Dr. Priya. Do stay on with us. We shall now go on to our next speaker, Dr. Akshay Nair, who's a senior consultant at the Department of Ophthalmology of Reliance Foundation Hospital and Research Center, Mumbai. And he is going to be talking on upper lid blepharoplasty, aesthetics and functional enhancement, and also lower lid blepharoplasty. So on to you, Dr. Akshay.
Thank you, ma'am. I think Lakshmi has given me the tough task of blepharoplasty in 6 minutes, so I'll try to do justice. So I think this was briefly covered, and I'll talk about it a little more in detail because we are also talking about functional blepharoplasty, if there could be one. So the most important muscle here that we are concerned with is the orbicularis oculi. It has three parts: the preceptal, the pretarsal, the preceptal, and the orbital. Now, functionally also they are different. It's a circular circumferential muscle which acts like a sphincter, and it's the only muscle that closes the eye. Now, the preceptal and the pretarsal are the parts of the orbicularis that respond to an involuntary blink. So these are the orbicularis fibers that you'd want to preserve as much as you can, because if you end up removing too much of this orbicularis, especially on the lower lid, you may end up with incomplete blink or lag of thalamus. So while it is largely a forgiving muscle, we have to be a little more aware of this. And also, when you inject, it's important to know the depth, because the orbital orbicular is always superficial to your corrugators and the procerus. So when we talk about blepharoplasty, it's not just a single procedure where you mark the skin, excise whatever comes with it, and suture it up. You have, based on the amount of or the type of tissue that you're going to be excising, you can classify this as a skin only, a skin plus fat, skin muscle fat, or only muscle, and then blepharoplasty plus other adjunct procedures that we'll talk about later. So the most important thing is marking, because if your marking is done, then half the job is done. And I looked at some images online trying to figure out what's the ideal way to mark. And you can see there are different ways people have chosen to mark. So there is no one way that is the most ideal way to mark. And there are different ways. Like, for example, the medial point can be either a single taper point or it could be an overarching hooded point. So as long as you follow the guidelines of making sure that you are addressing the lateral hooding and improving the pretarsal show, you should be good. So the important thing is to look for the most prominent lid crease, make sure that you rule out ptosis, and if you have diagnosed ptosis, to address that at the same time. The minimum amount of skin or vertical length of the eyelid from the base of the eyebrow to the lid margin has to be at least 20 to 22 millimeters. That's the bare minimum. Anything more than that, and the patient most surely will land up with lagophthalmos and incomplete lid closure. Always, if you want to leave a little more skin, that's okay, because in an upper lid bleph, less is more. So if you're removing less skin and giving a slightly natural appearance, that's perfectly fine, because if you end up removing too much skin, having to add anterior lamella in the form of a skin graft completely ruins the purpose of doing it. Remember, there are going to be slight gender asymmetries on where your eyebrow is positioned. So make sure you diagnose if there is any brow ptosis before you do a blepharoplasty. If there is severe blepharoplasty that leads to the appearance of an extra redundant skin on the eyelid, remember, a blepharoplasty will worsen the brow ptosis. So you need to correct the brow ptosis at that time. The most common indications for a blepharoplasty are dermatochalasis and blepharochalasis. Blepharochalasis is an inflammatory condition seen in younger patients, whereas dermatochalasis is seen more commonly in older patients as a result of aging. Now, this is the video that I'd like to focus more on, which is the eyelid marking. First is to measure that here I have about 26 millimeters to play with. So I'll mark out the lid crease. That's the most important thing. Now, what is the lateral edge of the marking? Draw an imaginary line from the canthus to the tail of the brow, and that will serve as the outer margin of your marking. And then based on how much skin you need to excise, you can taper it in. Now, this could be tapered slightly slanting towards the end point, or it could go and create an arch. I'm just rechecking. It was 26 millimeters, so I have 6 millimeters to play with, and that's what I've excised. Here especially in patients in whom I'm going to remove the medial fat pad, I like to create an arch rather than directly come down to a taper point. So again, a small video of a low upper lid bleph. So now that the marking has been done, you can either do a skin incision with a radiofrequency cautery, or you could go ahead and make the incision with cold steel. Upper lid, because the lid crease covers the scar, you can go ahead with a radiofrequency cautery for the skin as well. Now look here how medially the orbicularis has been preserved. But as I go laterally, a little bit of the orbicularis is excised, because laterally, if you remove the preseptal or the orbital orbicularis, that gives a slight lift to the eyebrow, because the frontalis there can act slightly unopposed. Now, in this case, what we are doing is what is called a brassiere suture. So a little bit of fat from the middle and the medial fat pocket is removed by opening up the septum and teasing the fat out. But after the fat is excised, what I'm doing is taking suborbicularis dissection and then reaching up to the orbital rim. About half a centimeter above the rim, you make a small pocket to expose the periosteum and hitch the subbrow tissue, the fat and the muscle, and with an absorbable suture, pass it through the periosteum. What that does is pushes the volume superotemporally and volumizes the eyebrow, and also fixes the eyebrow slightly superiorly, creating a slight subtle arch as well as a volume augmentation there if you're not adding filler or fat there. And of course, the skin closure is with an interrupted suture like interrupted non-absorbable suture like Prolene. So how does the patient look? So at about 2 weeks, you can see that the volumization is temporarily is good. The extra skin the hooded skin has been taken off, and the eyebrow has a subtle arch that looks good in women. In men, you don't want to do this because it will create a feminizing look. Now, where do you excise only skin? Younger patients, blepharochalasis, skin alone, or maybe a little bit muscle can be added. You may also want to tuck in the lacrimal gland if it is prolapsed. Skin and muscle, especially in older patients where you want to do an internal brow pexy and laterally you see more rooting. You can see how the lateral eyebrow is drooping significantly more. Again, middle-aged patient, especially in males, you would want to do only skin excision. You leave the muscle as is. The aim is to improve the pretarsal show and maintain symmetry on both sides. Skin plus fat, here you can see clearly there is a lot of redundant skin. Also, there is that fullness of the fat. So the fat pad has also been removed here, skin and fat. In addition, a lower lid bleph was also done. Now, cases where, again, younger patient with blepharochalasis, skin was excised, but you can clearly see that the repeated episodes of inflammation has pushed the lacrimal gland out, and that has been repositioned. This is important because you must recognize the preoperative asymmetry that needs to be addressed. So how do you reposition the lacrimal gland? Basically, you expose the lacrimal gland, and once you've seen it, you, on the undersurface of the lacrimal gland, pass a Prolian suture, any non-absorbable suture, and then hitch it to the undersurface of the periosteum, where the lacrimal gland fossa would be. You need to pass two such sutures and have your assistant tuck in with the bud into its position and then tighten it as the assistant is pushing it in. What this does is the suture holds the gland in place, and you can see that the before and after of the intraoperative pictures itself tells you the difference between what a prolapsed and a repositioned gland looks like. Postoperatively as well, you can see the difference at 6 weeks. It's fairly evident. Cases where you'd want to remove skin, muscle, and fat are cases like these where there is absolutely no pretarsal show, and also you can address the ptosis at the same time. Additionally, you can always add these little skin warts and tags that need to be excised can be done. Plain patients who come to you for xanthal excision, it's always a good idea to create that wow effect and improve the pretarsal show by doing a little bit of a bleph rather than just that medial patch of skin. You can give them a nice pretarsal show by excising skin and muscle. Again, sometimes there can only be medial fat pads that need to be excised. So sometimes you can give the patient only what they want. You can see that there's still some asymmetry in the lateral hooding of the skin, but if the patient is happy, that's okay. So don't try to chase perfection. It's the patient's happiness that matters. Again, a patient with xanthelasma where we've done skin, a little bit of fat because you can see the overhang, and a lateral orbicularis to give a slight brow lift. This is again the lacrimal gland repositioning. Sometimes you need to revise cases. This was a blepharoplasty that was done. You need to understand why the asymmetry is there, and that's because the lid creases were marked asymmetrically. So you will have to go back in and remark the lid crease and create a higher lid crease so that you can correct the asymmetry from before to after. And finally, cases where you'd want to remove only the muscle. This is apraxia of lid opening with patients with blepharospasm who do not respond to toxins. So, like we said earlier, the preseptal and the pretarsal orbicularis are responsible for the involuntary blinking. So, therefore, after making a lid crease, you want to expose the orbicularis, and here we are removing all the pretarsal orbicularis. Remember, pretarsal orbicularis and the preseptal orbicularis will cause a lot of lag of thalamus once you excise them. So you have to be careful and handhold the patient initially. What is your end point for removing the orbicularis? Once you start seeing the lash follicles. So this, of course, you can see is not bleeding as much because it's under general anesthesia and hypotensive anesthesia. Once you start seeing these lash follicles, you know that's your end point. And then, of course, you close this in a normal way. This is the upper edge of the preseptal orbicularis also being removed, and all you have left behind is the orbital septum. And closure is, of course, like you would for any other blepharoplasty. Putting in a BCL and a tarsography helps. This is again at 6 weeks. You can see the patient pre-surgery had such difficulty in keeping their eyes open and initiating lid opening, but post-surgery they're doing quite well. Additionally, adjunct procedures where you may have to do more than just a bleph are patients with facial palsy, where you have to do a direct brow lift, an upper lid bleph, lateral canthal tightening. The only thing is that because of the inanimation or the lack of motility there is always going to be lymphedema and fluid stasis. So as long as you can counsel the patients for that, acceptable symmetry can be achieved. So to summarize, I come back to my guiding principle slide where look and understand why you're doing a bleph. And if you can offer lateral hood correction along with improved pretarsal show, that should be your goal. 20 millimeters is the minimum number that you need to keep in mind. Sometimes less is more, and make sure you don't operate a patient with brow ptosis for blepharoplasty. Thank you so much for your time. Dr. Lakshmi, I'll do the lower lid later.
Yeah, of course, of
Yes,
course. You
yes.
have enough now.
Yeah.
Sorry
And
for
that
going a
was,
couple of minutes over time.
yeah, no, that was a wonderful talk. And I've heard you earlier in my ARC meeting, so very impressive. But this removal of fat, which you do, later some of these older patients, would it not make the hollowness more prominent or?
I think that's a great question. And that's one of the differences that we see, especially when we see presentations from, Caucasian population. And they often describe something as fat preservation blepharoplasty, especially in the medial part of the eyelid, where they sometimes take the medial fat pad and transpose it medium centrally. I feel that our patients in India like a little superotemporal hollow. So I try to remove a little bit, not too much. And another connected answer with this is sometimes you do a blepharoplasty and then the patient may come back later and tell you, hey, my fat has come back. So I always tell them a blepharoplasty has a shelf life of about 8 to 10 years. So it'll be, if for the next 8 to 10 years, you don't have to bother, or at least it'll take you till an age where you don't care enough. So
Very nice. Lakshmi, any question? Dr.
Yeah,
Shubhra, Dr. Milind.
Dr. Akshay, one small doubt. So then what do you suture to the periosteum for the
you can take the
fullness of the subbrow?
subbrow fat itself can be hitched in a non-absorbable suture and
Okay.
in an absorbable suture and tied onto the periosteum.
So expose the fat out, take it out, and then suture it back to expose the periosteum and
You can even include the lower edge of the orbicular is there. There is so much of tissues play available there. You can do that.
okay.
And Dr. Milind, Dr. Mopia, anything to add? Are you all there? Yes.
Yes, ma'am. Good.
Yeah, all good.
All good.
Thing to add to what Akshay presents. Wonderful talk, Akshay.
Thank you, sir.
Dr. Mopia, nothing?
No, ma'am. All good.
Both my residency and my fellowship teachers are there. So
Oh, oh, nice.
Shubhra and Dr. Mil.
Oh, good.
Ma'am, you're on mute. You're on mute, ma'am.
Yeah. Dr. Shubhra, anything? Shall we go on to our next speaker? You're on mute. We can't hear you.
Can you now?
Yes,
Yeah.
we can.
So actually, in the cases of blepharopalaces, okay, what is your selection criteria? When do you choose your patients? And
Yeah.
do you have recurrence of blepharopalaces even when you have had the quiescent phase of the disease? And if at all it reoccurs, what is your take on redoing such surgeries?
Yeah, so I've actually spoken about this to Dr. Milind, and over the years, I've changed my criteria. Where earlier I used to wait for at least a 6-month quiescent period, put them on an oral anti-inflammatory, give them even a little bit of steroids if needed. And if we have 6 months of no inflammation, then operate. But now I am actually have a much lower threshold because oftentimes these patients will come with 3 months to go before they get engaged or something like this. And you just, I'm more open and transparent about it that we'll correct what is seen now. But if it recurs, we'll have to go back again and you may get redundant skin over a period of time if your episodes keep coming, and we could do this surgery later on as well. So earlier I used to be more conservative. Now I'm a little more willing to operate in between episodes as well.
Thank you. Wonderful as always. Thank you so much.
Thank you. Thank you, Dr. Akshay. We shall now go on to our next speaker, Dr. Adit Gupta, who's again a consultant ophthalmic plastic surgery and ocular oncology from Mumbai Eye Plastic Surgery. And he's going to talk on targeting the fine lines and hollowing with Botox and fillers. On to you, Dr. Adit.
Thank you, Dr. Chitra, Team Eye Foundation, and Lakshmi. So, my talk is just going to be sort of a complimentary talk. Dr. Priya has already spoken a little bit about Botox and fillers, and I will just try to show you how they can be applied in the periocular region a little bit more in depth. So we all know that fillers are nothing but hyaluronic acid gels, which we commonly use in cataract surgery, right? Ophthalmologists are the first ones to have actually used it. And for cosmetic indications, there are multiple indications in the periocular area, and there are some non-cosmetic indications which is beyond the scope of this talk. So this is one of the commonest indications that a patient walks for a filler injection into our clinics. A refractive patient, which I'm sure Dr. Chitra deals with very often, just gets her glasses off one fine day and notices that she also has dark circles. These dark circles or hollows basically have been kept hidden by those thick rimmed glasses, and they get uncovered, and then it starts really bothering them. So these can be treated very easily by a small OPD procedures. The description has been done before, and they give very good replicable results if done properly in the right plane. And then these patients, once they are happy, you add on, and they become your patients forever. Now, what is the commonest scenario where you see these patients? They are usually young patients with a bony tear trough where they have a genetic tear trough deformity. This tear trough deformity usually extends from the medial commissure to the central part of the orbital rim, and sometimes may extend laterally as well, more in males, as you see here in this picture. Now, when we are thinking about fillers, what units should we target? Now, we all know that the periocular unit not only consists of the tear trough region, but also consists of the eyebrow unit, the temporal fossa, which sometimes we have to address when we want to lift the eyebrow. The upper sulcus, which oftentimes gets neglected, and Dr. Chitra pointed out that what to do about the hollowing. Fillers can be used for hollowing in this region if a blepharoplasty, too much fat excision has been done and a patient ends up with a hollow. And then the lower eyelid along with the midface, which is a unit which is contiguous. Now, already hills and valleys have been discussed, but with respect to fillers, we need to know about three pertinent landmarks in the eyelid region. One is the tear trough ligament, which is nothing but an overlay of the orbital rim. The second is the orbital septal and the orbicularis confluence, where there is another depression where the septum gets attached with the orbicularis, pretarsal orbicularis muscle. And third is the zygomatico-cutaneous ligament, which is basically the boundary where the malar fluid accumulates. Now, this is very important to know because usually if there is malar fluid in this region, we try to avoid fillers in this region because fillers are hygroscopic and will attract more water and cause paradoxical worsening of fluid. Regarding to techniques, 3 points have been discussed, but I follow a completely different pattern. I usually use micro-aliquot feathering technique where I inject fillers in multiple small locations in a feathering manner so that they get diffuse and do not form lumpy appearance. Or then you can use a cannula as described before. You can use cannula and inject it in 3 points and you can see the result immediately. Now, how does a filler injection actually look? So usually we apply half an hour of numbing cream, which is a mix of prilocaine and lidocaine, so that the skin gets numb and the patient is comfortable. And I usually like to use the needle. I begin with the central area. You see, you go directly oblique, hit the bone, retract back a little bit and deposit a small micro aliquot as seen here in the pre-periosteal region. It's very important to deliver this product in the pre-periosteal region. You don't want to be subdermal because otherwise it will show up and can cause Tyndall effect. So here I'm targeting the medial part of the tear trough and then I go to the lateral part of the tear trough. Lateral part is more sensitive because the zygomaticofacial nerve lies here. So sometimes the initial part might be a little tricky, but once the product goes in, usually patients never report pain because it has a little bit of lidocaine. And so that numbs the area up and the patients are usually very comfortable and their apprehension goes away once the first prick is made. So both the tear troughs can be targeted at the same time. Usually 0.3 to 0.4 cc is a good dose to begin with in either area. And then you can call the patient for a touch-up after a couple of weeks so that you don't overdo it. These are the results. So I always do filler injection the tear trough in 2 sessions. In the first session, I'll do a little bit and then I'll call them for a touch-up. And so build it up gradually because that also prevents Tyndall effect and you can gradually sort of taper and you can modulate the effect that you want to give as compared to this where there's a very minor sort of hollowing which can be treated off in 1 session itself. So these are the most ideal patients to do a lower eyelid tear trough injection. Sometimes you can combine it with surgeries as a combination procedure. Here, this patient underwent an upper eyelid blepharoplasty, and for the lower eyelid, she did not want a surgery, so she got a tear trough injection done, and you can see that it has given a good result. Now, coming to the eyebrow region, you know that after a particular age, the eyebrows start to descend because the eyebrow fat pad, the roof fat pad, starts deflating, because of which the physical support of the eyebrow goes down and then the eyebrows start flattening and the 3D contour of the eyebrow is lost. So fillers can be used very well in this region as well. We have published about it. Usually what we do is we enter with a needle and inflate the roof fat pad. So when it is inflated, automatically the eyebrow starts getting its 3D contour back and it artificially also elevates a little bit of the eyebrow hair. This is a small video which shows technique of eyebrow filler injection. It's very important to mark this area because there is one major vessel which lies here, which is a continuation of the superficial temporal artery. So I marked that here. After that, you enter with a a needle and enter the eyebrow fat pad and then gently massage or mold the filler over that region. This patient has also undergone eyebrow tattooing, as you can see, so you need to be careful about the anatomical landmarks in such patients. And then this is the bolus dose which I'm delivering in the temple region to lift the tail of the eyebrow. Usually you should inject not more than 0.1 at a given point, because that is the prescribed dose after which you can mold the injection, and then add a little bit of filler in the forehead region as well, because the superior orbital rim sometimes gets prominent in these patients because of bony resorption of the forehead. So same procedure is then repeated on the other side. It's a mirror image, so you have to balance it, and then you ask the patient whether they like the appearance and can call them for a touch-up after a couple of weeks. Similarly, this product can be used in Northeast Asian or Asian patients to fill the A deformity or the hollowing which is seen in that ethnicity. And in some younger patients who have allergies or who have hollow orbits to begin with, can be used as a filler can be used to fill these hollows and make the upper eyelid more voluminous.
Doctor, 1 minute more.
Yes. It can also be used in patients who have only eyelid retraction. We all know that we perform surgeries for eyelid retractions. So here you can see that filler injection can be used to treat patients of thyroid eye disease who have eyelid retraction only and not proptosis. It can be done either through the skin through the transdermal plane, where it is used to stretch the levator, or it can be done through the subconjunctival plane, where you evert the eyelid and deposit the product in the levator plane to stretch the levator. So these are two more options that you have if you want to avoid a surgery. Nowadays, steroid injections are also used, but they work more in the active phase. So if a patient is already burnt out and there's just stretching of the levator, then you can use these injections. These are obviously temporary, so you might have to repeat them. Last but not the least, they can be used to correct complications which have arisen from aesthetic procedures. This unfortunate incident happened in this patient where extra skin was removed via transcutaneous blepharoplasty, and she ended up with an ectropion. You can see on the left side more than the right. And a filler injection was just done to buy time and stretch the lower eyelid so that we could buy 2 or 3 months before a repeat corrective surgery could be performed. Now, obviously, there are complications with any procedure involved. Eyelid filler, as mentioned previously, has not many complications if done correctly, but there are certain minor complications which matter to the aesthetic patient, like fluid accumulation. So you have to counsel these patients that eyelid skin is thin. The filler that we use is hygroscopic, so it imbibes water. So a transient increase in puffiness of the lower eyelid can be seen in some patients, which over a period of time resolves, as seen in this lady, where in a picture before and after, you can see that after 3 months, the fluid has resolved completely. Commonest complication that we see is contour irregularity because of the thin skin. So you need to deliver the product at multiple planes and also try and deliver less product so that you don't end up with a lump like seen here. This certainly needs to be dissolved. Bruising is very common because the orbicularis is vascular. So you should try and use all possible maneuvers to reduce the extent of bruising, or you can end up like this, which is very difficult to deal with. This takes almost 1 or 2 months to resolve. So you should not end up with a major bruise. If you notice a bruise earlier, you should remove it. And certain products should not be used in the eyelid region. Like this lady had a product which is also called as Sculptra, which was injected, and then it ended up with a granuloma, which eventually had to be removed. Infections also are common. Infections are mostly low grade. They are called as biofilms. And these, if you do end up with an infection, then the product has to be removed, and it should be watched for, because these are recurrent infections. So to summarize, if you want to inject the tear trough, always choose a young patient with a bony true hollow and thick skin so that you can hide the filler. Inject always in the preperiosteal plane, not in the subdermal plane, especially in the eyelid region, because the eyelid skin is not very forgiving. Avoid patients with sinusitis, rhinitis, or allergic eye disease because they have very thin, crepey skin. Blepharochalasis patients, they always never do well with fillers. And say no to fillers in patients with pre-existing hyperpigmented skin because they never get good results with fillers. Over a period of time, I'm doing fillers since the last 10 or 12 years, and I have started doing less and less of eyelid fillers, because although we say that the filler lasts in the eyelid only for 1 year, I've seen patients who have gotten filler done 4 or 5 years ago, and some amount of the product still stays there for a time period which we cannot predict. So building up fillers should be done very cautiously, very carefully, very slowly. And you have to choose your patients very well if you want to have a happy patient from a tear trough filler. Thank you.
Yes. Thanks a lot, Dr. Adit. That was a wonderful talk, and you could actually not talk on little bit of Botox because I think there's so much. 6 minutes is
Yeah.
crazy. You might as well do justice to one. No, I do hear of patients taking repeated Botox and all that. So, is there any warning or any advice you would give to these patients, or there's not much that goes wrong?
I myself take Botox in whatever workshops are available. So
Wow.
I take it once a year. It's good for ophthalmologists. We are frowning all the time whilst
Yeah.
focusing on the microscope. So at least in this region, it helps us a lot. But repeated Botox usually is very safe. There are patients whom I'm sure Shubhra, Milind have been injecting for more than 20, 25 years now, and they still come back to them without any major side effects or any untoward incidents. Fillers, on the contrary, you have to be a little careful. Your injector has to be more cautious and more sensitive. Otherwise, you can end up with filler fatigue or sometimes overdoing fillers, which then changes the appearance of your face over a period of time. So I'm more conservative with fillers as compared to Botox. Botox usually wears off in 3 to 6 months. So repeated injection shouldn't be a problem with Botox.
Thank you very much, and open to discussion. Dr. Shubhra, Dr. Milind, Dr. Mopia, anything?
As always, my question to you is that yes, we are all getting away a lot from the periorbital fillers and fillers in general on the face because we are seeing the overfill effect. We are seeing the long-term complications and fillers staying for too long. So, are you playing around a little bit more with the Botox for the full face and the collagen builders or the biomodulators more on the skin?
With Botox, for sure. Lasers, Prerna does. I'm not
Just
very
for
good
that, for
at
the
lasers
are
because I was never good at physics. But I actually have started playing around more with fat.
Mhm.
So we used to always speak about fat being a criminal and it causing a lot of lumps and granulomas. But nowadays, with better harvesting techniques and processing of fat, it is starting to give very good results, especially on the face, uh, uh, as compared to fillers in certain indicated scenarios. So I have actually convinced myself to start doing more and more of fat injections along with combined with surgical blepharoplasties. Um, but I don't know, time will tell. Maybe after 5 years, I'll be able to comment if it works better than fillers.
Yeah, I have practically, kind of shifted gears from doing too much of fillers and loading the face with fillers, but playing around with more non-invasive, which is botulinum toxin, as you said, is much safer, and you
Yeah.
cannot go wrong with botulinum toxin, with a lot of skin collagen boosters, with energy devices, and then an overall holistic approach to the facial aging. And yes, fat definitely is a topic of debate, which you don't have time for right now, so we can leave it for another time. Milen Mopia, please.
Sculptra has got launched in India recently, 2 days back. So we can all try Sculptra now instead of fillers. Because in West and in UAE, everyone swears by Sculptra. That is very good. I mean, no swelling of the face, very good collagen reactivation. So we have to all try Sculptra and see how it works in our hands.
Yeah, I think in this realm of discussion,
She has a network issue, I think. Dr.
Yeah, I
Milind?
think just to add to Mupia, I think while Sculptra has been launched, just a couple of weeks ago, there has also been a paper on
Yeah, I
PLLA, which
saw
is
that paper.
Sculptra.
I saw
Sculptra
that
induced
recent lots.
blindness as well. So
Yeah, yeah.
while it is another filler that's coming, it's stimulator, it also can cause blindness. So
Yes.
safety profile is pretty much same as HA.
Dr. Milind?
Except the
your
swelling.
thought?
Yeah, I think Sculptra might have an advantage when it comes to lowering the Tyndall effect, I feel. So it could be a good option. It could be a good option into the socket for patients who have prosthesis, which is in ophthalmic. So there's a place for Sculptra. I'm glad that it's launched, and we would have to figure out where it fits into
Yes.
the whole thing.
Yes.
Yeah, it's still the most popular because you can modify it so quickly.
Thank you. So we go on to our next speaker, Dr. Shubhra Goel, who's going to be talking on the darker side of fillers and Botox addiction. I think 8 minutes is not going to be enough about what she's going to tell us, but I think we need to know something not too attractive about it too.
Okay, is my screen visible?
Yeah, why is it that we see your image and it is not connecting something different?
You're not seeing my presentation, is it?
No, we are not seeing your presentation now.
Oh, okay. Okay, give me a second. I don't know why. Meanwhile, if there are any questions, please go ahead. I don't know why, what is the problem? Because I just loaded it.
Actually, even your image which comes, no, when
Mhm.
you're talking, it appears that that image is still and you're talking separately. I don't know.
So is there a lag in my...
Yeah.
Ma'am, can you just continue the discussion while I sort this out?
Yeah, or should we
Dr.
go
Ajit
on to
is-
the next speaker? Maybe that.
I can see now. Is it seen
No, it's not seen.
now?
No. We
Okay.
did see it before, no? You did
Yeah,
show
yeah,
it.
yeah. Okay. I think Akshay can take over and I can join after him. No problem.
No, I think Dr. Maupia has to talk or Akshay. Okay, Akshay.
Akshay.
Akshay, you talk. Yes, Akshay.
All right, so I'll share my screen. Oh, no. Um, yeah, this is lower lid blepharoplasty.
Dr.
Okay,
Shubhra, maybe
Dr.
you stop.
Shubhra has started screen sharing, so.
Yeah, Shubhra, would you stop screen sharing and let Akshay do it and then you come back to us?
So,
Yeah.
all right, so I'll talk about lower lid blepharoplasty. So I think I'll be the third speaker in the webinar to reference the fallback paper that we keep reading, which is the Hills and Valleys. And I'll talk about assessment, transconjunctival, transcutaneous. I won't dwell too much on complications. I know that's something that Dr. Milind is talking about as well. So I think when we assess a patient, this is I think a very, very good starting point, and it's great to have the author here with us. We've all borrowed from this, and our aim of blepharoplasty is to make sure that the lid cheek junction is smooth. There is a smooth transition from the lid to the cheek without any bumps or lumps or hills or valleys that we normally see. Now, a patient like this would be a great starting point for anyone who's looking out to start doing a blepharoplasty. What we need to understand is we identify that there is lower lid fat prolapse. We need to make sure that we are not going to operate on malar mounts. Oftentimes, patients with thyroid eye disease can also present with swelling around the eyelids, erythema, and fat prolapse, which can be mistaken to be signs of aging, and also to identify where skin needs to be excised in addition to just fat. So the guidelines that even the paper talks about is to look at fat prolapse not just in primary gaze but also up gaze, because when you look up, the superior rectus and the LPS contract, the inferior rectus and the lower lid retractors relax, allowing the septal fat pads to bulge out. Now once that bulges out, the fat pads become worse on up gaze. And similarly, when you look down, the lower lid retractors and the inferior rectus contracts, and it looks better on down gaze. Now, when you have older patients, you see the same thing happening, worsening on up gaze and improving on down gaze. But of course, here you see a little bit of redundant skin as well as a little inferior scleral show, suggesting that skin as well as the canthus may need to be addressed. And that's how you can plan a transconjunctival versus a transcutaneous. Patients like these, where you see so much of fluid, need to be tackled a little more carefully and possibly step away from, unless you have no other option but to operate these patients. So what about the landmarks that you look for? You make sure that the lateral canthus is in position, otherwise you need to address that as well. Make sure you look for each of these structures that was mentioned in the paper. So the first hill, like was mentioned earlier, is the orbicularis. The just below that is the first valley, which is the septal confluence, which is not prominent in many patients. It's prominent in the picture above, but in this gentleman, it's not. The next hill that you see is the fat prolapse. Then you have the tear trough hollow. And finally, if there is a cheek fat pad in place, then that becomes a hill. But if it has descended, that becomes a deeper hollow under the tear trough. So our aim is to make sure that there is a plateau here. So either we take the hill and flatten it out, or you take the hill and put it into the valley if it is too deep. And that's the basis for deciding how do you approach a surgery. Now, in this case, you can see that this is fat prolapse. There is a bulge, a hill, and the valley underneath the tear trough is not that prominent. So a simple fat excision has led to a smooth lid cheek junction and a transition that's very good. But in this case, you can see that the hill is really not that much. The fat prolapse is not much, but it's more of a slight depression or a valley. So here you would rather fill than go ahead and do a blepharoplasty, also considering this patient is far more younger. So again, similar examples here. The patient was okay with the hollowing because her old photos had a prominent tear trough hollow. So we went ahead and did a transconj fat excision. But later on, she wanted that volumization also to be added. So we've gone ahead and added HA filler to create the smooth lid cheek junction. Now, in this patient, all you see is a hill. So the only thing he needs is to flatten that hill, a transconjunctival bleph fat excision. But sometimes fat excision alone is not enough. And now here you see in this patient, you have a very prominent hill and a very deep valley as well. It appears more prominent in upgaze. She does have a little malar fluid, and it settles down significantly on downgaze, but the hollow is fairly deep. So in this case, excising the fat alone will not help. What you need to do is take the hill and push it into the valley with a fat transposition. So a transconjunctival blepharoplasty is where you go in, and I'll quickly run through a video. So the fat pads, you need to know the medial, middle, and the lateral, and then you have the oblique between the middle and the medial. What we do is transconjunctivally, we infiltrate a little 4 to 5 mm below the tarsal edge. You can create an incision. You could either create just small pocket-like incisions or a continuous incision along the entire edge of your wound incision. Gently dissect, and as you go in straight down, you would see you directly reach upon to the septum. And when you see the septum, you need to be a little more delicate and try to tease out the fat. Uh, Again, you don't want to infiltrate too much such that you do lose context of how much fat you have excised. So you can inject as you dissect such that you anesthetize as you are excising. And then the fat pads you can carefully cauterize and excise. Always cauterize the base so that the vascular fronts or the vascular stalks don't bleed and retract into the orbit. The medial is especially is known to be very vascular. Again, you inject a little and then cut it out. So in this case, this is just a simple fat excision. The lateral fat pads need to be chased, especially in men, because they can be very, very notorious in being hidden under the edge of the bone. And in a lot of patients, you can leave them with just 1 or 2 sutures, but I prefer more for the patient safety, but also for my peace of mind at night to take at least 2 or 3 such sutures. So these are cases of simple fat excision, limited fat excision, where you'd go in transconjunctivally and remove the little bulge that you see. Here, even the lateral or the middle fat pads were not touched, only the medial fat pad. This actually could have been a patient whom you could have done with filler as well, but they were keen on a longer lasting solution. So this is a case of transposition. Now, how do you do a transposition? You identify the fat pads. You can see the medial and the middle, the
Doctor,
inverse
1 minute
shoes.
more.
Yeah, it's okay.
Yeah,
Carry on.
the inferior oblique and the inverse shoe shine sign. Now, what you need to do is create a subperiosteal pocket for about a centimeter under the orbital rim. And here what we have done is passed a proline suture through the skin and the orbicularis, and then under that pocket of periosteum, come out through the wound, engage the medial and the middle fat pads here, and then push it back again. So basically, you're dragging the fat pads from the lid location and filling the tear trough. So your entry points on where you put the bolster have to be at least 1.5 centimeters below the orbital rim, because that suture has to drag the fat all the way across the edge of the tear trough hollow. And then you can see that once that is done, you push it out through the skin and remove it and tie it over bolsters. These bolsters are taken off at about 10 to 12 days. I like to keep them for a slightly longer period, uh, and making sure that they don't get infected, because patients need to be very hygienic about this. So transcutaneous blepharoplasty I'm moving more and more away from. I'd rather end up doing a transconjunctival blepharoplasty with a small skin pinch, rather than make the incision and the dissection through the fat pads, through the skin itself. To identify how much fat skin needs to be excised is by doing a small skin pinch, which could be done sitting up as well. So here I'm pinching the skin and see the lower edge of the eyelid has come down. Whereas now when I'm pinching the skin, there is no movement of the eyelid. So the minimum amount of skin that you can excise without altering the position of the lower lid is what you should be aiming for. A subciliary incision is important, no more than 3 or 4 millimeters from the lid margin. And here, because we are not going to be able to hide the scar, it's better to use cold steel rather than radiofrequency cautery to make the incision. Just skin is being excised with a little bit of orbicularis, and dissection along the lower edge of the wound to expose the septum. Once you have exposed the septums, you will see the fat pads like you would see in a textbook picture. You can identify these fat pads as they are. Now here we are opening up the septum, and you'll be able to see the anatomical demarcations that we would see. You can see the medial here, the middle over here, and then the lateral fat pad. Based on how much you want to excise, again, you can excise them. I'll quickly rush through that part. Inject and excise to make sure that you don't end up having too much of bleeding. You can do a GRED maneuver here, which is globe retropulsion, and the eyelid is already pulled down the lower edge. The end point is where you don't see too much fat bulging out. Here you can see when the patient is lying down, you feel there's too much of hollowing, but when the patient sits up, eventually it heals very well. The wound is closed in layers with orbicularis first and then with skin. And this is how the patient looks at about 3 months post-surgery. You can see that faint line just under the lid margin, but there is definitely a few years knocked off the patient's lids. So I'm moving more and more away from transcutaneous unless it's a really bulky eyelid where you don't have a choice but to do that. But I prefer to do a transconjunctival fat excision with a little skin pinch here. Again, a quad bleph upper and lower lid knocked off at least 15 years of the patient's face. And finally, in those cases where you still have those fluid mounds, you will have to leave your autograph on the patient's face, as Dr. Milind says, which is a scar, but at least that mound is taken care of. So this is a transcutaneous bleph with the malar mounds being excised with a crescent-like incision on the cheek. So complications, I won't dwell too much, as just few principles of how to avoid complications. Make sure you don't, use blade over radio frequency if you're doing a transcutaneous route. Meticulous closure is important. Again, less is more. Remember, do not excise too much skin. The lower lid is far more unforgiving compared to the upper lid. If you see lid retraction, like Dr. Adit mentioned, use adjuvants. You could use fillers, 5FU, steroids. Earlier you go in to try to prevent the retraction, the better it is. These are some cases of hematomas, of post-blepharoplasty lower lid retraction, and almost ectropion with canthal disinsertion that all needed revision surgery, except the hematoma patient. So to summarize, you need to thoroughly assess the patient to know what procedure works well in your hands and what would give the result that they want with realistic expectations. You have to customize them, whether you want to do a fat preservation, fat transposition, transcutaneous, transconjunctival, and now, of course, you've got fat pearls and fat grafting as well. And if you feel that you've landing up with a complication, the earlier you recognize and the earlier you go in and treat it, is the better the outcome will be. Thank you again, Dr. Lakshmi and Dr. Chitra, madam, for the invitation and the opportunity to speak today.
Wonderful talk, Dr. Akshay. Yes, Dr. Milind, your thoughts, anything to... You have to unmute yourself. Dr. Milind, yes.
Sorry, Akshay, can you hear me?
Yes.
So how often do you use the skin pinch apart from as a choice?
Yeah.
Rather than going transcutaneous?
So if you saw the pictures that I showed with those huge bulbous eyelids,
Right.
they're going transconjunctivally and then keep hunting for the fat and getting it out becomes too tedious. So those are the cases where I'd rather go transcutaneous. But in women, especially, in the 50s and 60s, where there is just a little bit of fat prolapse, but you know that if you excise that fat, you'll end up with a little redundant skin. Where there's not too much fat that you need to go hunting, I prefer transconjunctival and then a skin pinch. Uh,
Right. And what's your preferred anesthesia for the
So
lower?
first is infraorbital anesthesia, just to numb at least the medial half of the lower lid, and then local infiltration on these through the skin, transcutaneous, and then after instilling a little paracaine with a DEMAR, I pull the lid down and then transconjunctival, just a little bleb wherever I'm going to make the incision. I think just as you taught.
Great. And any other comments from anyone?
Yes, Dr. Subra, Dr.
Yes.
Mohammed.
Can you now hear me and see me properly?
Yeah.
Yes,
Oh,
much
yeah.
better, much better.
So much better. It
Okay,
was
no, I shifted from Wi-Fi to data. I think there was some problem. So, Akshay and Milind and everybody on the panel, which is the most bizarre complication or you have seen with your low lid blephs?
Most bizarre. I mean, not my complication, someone else's complication.
Anyone or yours, I mean, it doesn't matter. Yeah.
I've had a patient who had bleph with fat grafting, but the fat was grafted subcutaneously. So the patient had these little pimples and boils all over the lid, which was actually fat.
Okay. Why I brought this point is because I had one very bizarre complication, and thanks to my better half who was on the panel to save my credentials and my registration. So what happened is on table when we kind of expose the fat pads, we have a habit of giving the local infiltration into the fat pedicle, and this was a guy from Africa, and he was heavy and he had very grade 4 fat prolapse, and I just kind of did and very, very, according to me, very judiciously gave the local infiltration in the pedicles, and everything went off smoothly. It was under local anesthesia with sedation, and when I got up, I found bilateral third nerve palsy. Okay, so it was like a screwed up eyes with bilateral ptosis, and it's like I'm not able to open the eyes, and literally I literally peed in my pants, and I thought, okay, my registration is gone, I've done something wrong. And I called up Rashmin, and he said that he has seen one of the cases like this. So what happens is, why I brought this point is because I think it is important for us to understand is that there can be a percolation of the lidocaine into the open orbital space, retrobulbary, and it can hit into the nuclear area. Very rare, very bizarre, but it can happen. But it recovers, it is transient, and patient is normal within few hours of time. And there is one case report of this, and another one was what I saw. So yeah.
oh, nice. Okay.
Yeah, you got it. You're too quick, Akshay. Yeah, so this was interesting one. Okay, so any other questions, Milind, Mopia, anyone on the panel? Ma'am, if you have any questions for Akshay. Otherwise, I'll see if I can share my
Yeah.
screen.
Yes, you could share your screen.
Okay, now I hope it's visible.
Yes,
Yes.
yes, yes.
Okay. Thank you, ma'am, Dr. Chitra and I Foundation and Lakshmi. And it's a pleasure to be on board with such an amazing panel and to learn and to relearn every time. And the topic given to me is bizarre. I mean, the dark side of Botox and fillers addiction. I mean, how do I put it? How do I make it? I don't know. I've tried my best. I've tried to make it a little more fun than making it too serious because there are a lot of parameters which you want to look at. So when we say the pursuit of perfection becomes a dangerous obsession, I think it is in every scope of life. So I'm just going to share some videos with you to begin my talk, and I want you to pick up the essence out of it. So here I am, and these are my past affiliations and my training.
Kate Hockley has a perfect face. I've had it here, I get it across my brow. But at 21, she thinks she's looking old. So believe it or not, she's had a modern day facelift without going anywhere near a scalpel.
I don't think it is a medical thing at all. It's not an invasive surgery. It's just Botox.
Every 5 to 6 weeks, Kate has a beginner's version of what they're calling.
So this is one of the scenarios which I'm sure is kind of becoming pretty common.
Producing the soft, dewy face of an adult child.
Fire away.
Meet the man behind the Madonna, the incomparable Dr. Frederick Brandt.
It won't hurt a bit.
You inject Madonna's
I
face?
cannot tell you what I do to her. She may just come for a little skin treatment and make advice on creams, but I never tell what I do. Just like if you came in my chair, no one would know what I've done to you.
You'd never tell.
I'd never tell.
Okay.
Botox rhythms got me on the move. Everyone inject.
If Brandt has a slightly Hollywood aura about him, it's because not only does he use more collagen and Botox than anyone else in the world, he uses a great deal of it on himself.
Yes, I'm making a comeback for the 100th time.
His 59-year-old face is an extreme version of this new look.
Another scenario.
When you look at me doing that, frowning, you think, yuck.
I think you look angry.
For this generation, looking your age means looking a fright.
Oh, the nicest is possible way you don't ever want to look.
And then to summarize,
She's found the holy grail of cosmetic procedures.
Thank you. So, and it's wonderful. I don't have to ever get old, and I don't wish to, and I'm not going to.
And Kate believes she's discovered the fountain of youth right at the end of a tiny hypodermic needle.
I enjoy it because I know that it's giving me long-term results.
Well, you hope it is.
Oh, it will.
She's
okay, so these were some of the videos which I just picked up. It's a beautiful documentary, put together for the Australian population, but I think the issue stays global. Not so much in India as we see as of now, but I'm sure it's going to be there in few years, if not few decades, So what are we talking about? See, the cosmetic procedures is a global phenomena. It is just having a rage all over the world, and especially with the injectables, because I'm going to talk about injectables and not the surgical procedures, which is another talk in itself. And this is influenced by many things. It's the lifestyles which are changing, the media culture, the celebrity influences, the youth per se, having different
Just a second, Dr. Shubhra. Is it just me or is the volume too low for Dr. Chitra? Can you hear Dr. Shubhra?
Yeah, it is lower than others. Maybe she can increase the volume on her laptop.
Yeah, it is on the full now.
Yeah, fine.
Okay. So, so it is also governed by the youth, the today's generation, the obsession in the society of how we want the instant solutions. And if you look at the Indian market today, by 2024, we are talking about 2.5 billion, which is going to be around 4 billion by 2023. So we are not 2033. So we are not far behind, but there are a lot of aspects to what we're talking and what we're going to say. So what is happening with injectables per se is basically the instant gratification and the lasting dependence. And this is what causes a psychological trap, a kind of an addiction. It's kind of a psychological addiction of looking a certain way in front of, especially the social media, the cameras, and the selfies. Though these are semi-permanent and temporary treatments, but there is an urge to have them repetitively because now you kind of got used to a certain look. Remember the first video where the 21-year-old girl has no wrinkles, but she still wants a look. And the last video, which is a complete contrast and says, now I've got my holy grail. I don't want to age. I don't really want to age about it. So this is what is happening in our society. While these are not as bad as having any other addiction like drugs or any bad habit, but these cravings, the tolerances, the withdrawal symptoms with the patients who are really addicted to it are really high. And believe me, I have seen few of them. We cannot really highlight them in this talk. So what's happening behind the curtain is a body dysmorphic syndrome, because most of these patients are not happy. They feel they're not looking certain way. There is a perception drift. They're never satisfied in a certain way. They always want to change their looks. And thanks to our AI, people are actually coming with apps which want to say, I had a patient who put his picture and says, now this is handsome me, this is charming me, and this is beautiful me. So you make me one of that dog. And I was like, you look great the way you are. I really can't make you what you want me to do. And definitely in this era, there is a digital amplification. In fact, in Zoom meetings like this, we maybe, I don't know how many of us, not in this cohort, but we will put filters, we will have backgrounds because we want to look a certain way, a certain angle of pictures being taken, and we all do it at some point of time in our lives. So there are some warning signs with these addictions, especially again, I'm emphasizing with injectables. There is an increasing frequency, there is a chronic dissatisfaction, there's so much of doctor shopping. You don't know where to go and whom is the best injector, especially with the social media projecting the doctors or injectors in a certain way. We don't have the quality check, and we have an obsessive focus, and people are usually going through some kind of a psychosomatic disorder at the back curtain of it. Okay, so there are devastating consequences both in terms of physical and mental crisis, and I'm not going to go into detail, but there are complications of Botox and fillers if not done by the right hands. And these are some of the patients referred to me where there were granulomas, there was vascular compromise, there were these sausage deformities, and the delayed hypersensitivity reactions and lumps and bumps, which we have been talking about. And with Botox, believe me, I've seen patients who are doctors who have come to me with facial paralysis post Botox, done by someone who doesn't really know how to inject, or maybe done by someone who's expert in it, God knows, but they're so obsessed with a certain kind of look that they really forget how they used to look before. And when I asked them to show the previous picture, I said, you look so pretty. I mean, your face was so soft, so innocent, so natural. And what have you done to it? Because there's so much of product on your face. Obviously, I don't think this talk will be completed without the role of social media and the culture, because the viral contents, the self-injections and this glorification of watch me addicted to filler or Botox, see how I inject myself.
1 minute more.
Yeah,
Okay,
kind of thing.
yeah.
And
So carry on, Shubhra, we are looking forward to hearing you. Yeah.
Thank you, ma'am. And then there are these celebrity cultures going on. There are Botox parties going on. There are groups. There are these Botox women where doctors are themselves going and injecting. Nothing, no harm in that, but I think there has to be a balance about it. So social media has kind of transformed the cosmetic procedures from very personal and private choices to a public performance. And this is dangerous, because if I have to really talk about myself as a patient, and if I go to my friend for an injection, it's a personal and a private affair. I don't want to really make it public. And I want to do it in a certain way which looks natural, presentable, and sustainable. Now, there was a very recent article in 2025 August by Hindu, about the unregulated cosmetology clinics threatened by health and safety of Indian patients. Now, let's go focus back onto the Indian patients. And Dr. Rajita Damishetty, who's a dear friend, is kind of leading this whole battalion of what's going wrong in India. And I did talk about it in the beginning. There is a lack of action, there is a quackery rampant, and there's a lack of enforcement, and there are no laws literally existing. So how do we really rate that Akshay, Milind, Mopia, or anybody on the panel, Adit, Prerna, anybody who's injecting, or myself, is better than someone next door who's doing same Botox and fillers? Because patients are not really looking at your credentials. Patients are not really looking at what you're giving at the end of the plate. What they're guided by is a social media influence, some pictures, some celebrities, some quick fixes, and they want a certain look. And that's where we are landing in trouble. But the good news is we, as the responsible injectors, physicians, and surgeons, for our fraternity at least as a group, have a role to play, because we are scientists, we are trained injectors, and we have a huge responsibility to guide our patients in the right way. Because at the end of it, we are the psychologists for our patient, we are the treatment physicians, and we are the injectors and surgeons. So we need to have a proper screening, selection of patient, and a mental health support, which is of very paramount importance. I think it is not wrong to say no to a certain patient who demands something very unrealistic, or you see it as a red flag. So obviously, you need to have everything in place, and recovery is possible. I have had patients, not too many, but I guess around 10, who were into this category of addiction, more related to body dysmorphic syndrome or some psychological trauma, which has quite of kind of a bullying kind of a situation, which brought down their confidence at work or at personal life, and they feel in a certain way. I mean, I can give my example without any fear and shame, that I never liked my nose because I thought the nose was too bulky for my face. And it only took me time to understand my own facial features and accept it in a certain way to say, okay, this is great, you know. So we all go through it, and I think we have all gone through it in our lifetimes, and we have to balance it. So beyond the surface, there are hidden risks. Early recognition is needed, and true beauty is definitely a genuine confidence and a love within inside. And we, as a professional background people, have to support it in a very, very big way. So I always feel that let's promote the informed choices in a very, and have to be very, very compassionate aesthetic medicine physicians. Compassion is the key here. We are not here to just mint money or to treat patients because, you know, that's what they're asking for. Of course, that is needed, but we need that. Coming back to that, do I inject Botox and fillers, and am I addicted to it? Well, I do inject Botox fillers on my face, and you can see my transition. And as I sit in front of you, I am now touching 50 next year. So I don't want to look 50. That doesn't mean I don't want to age, but I really need to age fabulously. And I'll keep doing work on my face, which is needed as per my features, my ethnicity, and my safety. And there are perfect examples. I mean, this is my patient who was operated plus injected, and she sent me a picture like this of a profile. This is not the real pre and post, but a profile picture sent by her. And people are happy. So it's all about choice. It's all about choice of where and how to start and to lead with this. And this is a beautiful video.
This is a film about 6 remarkable women with an average age of 80.
One looks different to the other. I'm now 85 and I don't feel like slowing down yet.
6 women to inspire us and show us that old age doesn't have to be grim and boring.
I don't give a damn what people think of me or the way I dress. I dress for myself because I love style and design and colour.
Women who can show us how to look $1 million, even in clothes from charity shops.
I think I would say I'm a bit unusual for my age.
6 very stylish, very different women who haven't had Botox or plastic surgery.
My goodness, definition's good. We don't want too much definition.
They're redefining the aging process. They're doing it with attitude and a great wardrobe.
I don't want to be too over the top.
We can all learn a thing or two from these women.
You know, I did this film with Errol Flynn. He was very good. He taught me a lot.
Not just about style, but about life itself and how to enjoy and make the most of whatever time we all have left.
Hurry up. Yes, it must have done enough.
So it's all about how we want to live our life. Science will always be there to support us, to guide us, to do some reformations, rejuvenations around the face. Cosmetic industry, anti-aging, longevity is the future. We are shifting from injectables and surgeries to the cellular level anti-aging, and that's the future according to me, not even injectables. But there is a fine line on how we need to balance the complete scenario in our life, want to project ourselves, whether we want to age gracefully or we want to age fabulously. Thank you so much.
Lovely talk. Lovely talk. I wish many people get to watch this webinar. I think you all have to help me send it across. Thanks a lot, Dr. Shubhra. Anything, expert opinion from Dr. Milind and Dr. Mopia before we go on to Mopia's talk?
No, it was a wonderful talk. It was very nice. The need of the hour type of talk.
Yeah.
It's nice.
Dr. Milind? Was she trying to close your shops or was she trying to keep it open?
No, it's these philosophical
Random.
talks are more important than the actual procedures and the topics. Thanks, Shubhra. It's wonderful.
So we go on to our next speaker, Dr. Mopia Goswami, who's going to be talking on when can we go wrong, upper and lower blepharoplasty risks. On to you.
Am I audible? Good evening, everyone.
Yeah.
Good evening, everyone. And I thank Chitra Madam and the team of Eye Foundation for the opportunity. And after a wonderful talk on upper and lower lid blepharoplasty, this is a talk for our young surgeons as to how to avoid complications and what can go wrong. So where can we go wrong? The most important thing we should understand is that this is a cosmetic surgery, and what the surgery can deliver and what the patient expects has to match. Problems happen when both are not in sync. Nowadays, the patients in metro, they do not have the space and time for the journey, the healing period, the ecchymosis, the edema, and the small scar that we can get, and they are used to lunchtime procedures and instant recovery. And therefore, a detailed discussion regarding the incision, the healing journey, and the expected outcome is a must prior to the actual surgery. What can be potential contraindications, relative contraindications? As has been discussed, it could be a psychological issues like body dysmorphic syndrome, severe dry eyes, active inflammatory cicatricial skin conditions like eczema and psoriasis, and multiple revision surgeries if the anterior lamella is very short and we are planning to give a skin incision. So clinical evaluation avoids a meticulous clinical evaluation avoids error in judgment. So there should be no error in picking up a brow ptosis, picking up a ptosis, or a lacrimal gland prolapse when we are trying to do a upper lid blepharoplasty. So if brow ptosis is not corrected, we would end up in brow droop. When we do a upper lid blepharoplasty, we would be excising a lot more skin than it's required. Ptosis, if missed, becomes more evident once loose skin is removed. And lacrimal gland prolapse, if it is not addressed during upper lid blepharoplasty, it would leave a fullness at the lateral part and does not give a very youthful appearance and good appearance to the upper lid. And the patient will be unhappy. In the lower lids, we should check for lateral canthal tendon laxity, horizontal lid laxity, and we should optimize the health of the patient prior to the surgery. This is a picture showing combination of brow elevation along with blepharoplasty, and therefore we have got good result. This is one other gentleman in which brow elevation was combined with upper lid blepharoplasty, and you can see the before and after. This patient, in the first picture, you can see the ptosis is hardly visible because there is eyebrow elevation on the left side. Once we correct the eyebrow manually, we can see that the left eye upper lid is drooping, and therefore the ptosis surgery was combined with upper lid blepharoplasty and also squint surgery, and therefore we have got a wonderful result. Lacrimal gland repositioning, as I have said, has to be combined along with upper lid blepharoplasty if there's lacrimal gland prolapse. Here you see a patient before surgery, after quad blepharoplasty, where you see that the lateral fullness is still there. On closure of the eyelid, the temporal area is still full and it does not give a good result. And here you see before and after. After that, as a second procedure, where the lacrimal gland was repositioned, and you can see that the tarsal show has increased beautifully, and the lid crease is seen well. Now, as has been told in the previous talk, the lid crease marking has to be perfect or fastidious. There should not be a tarsal show asymmetry because it looks very bad when the patient looks down, as you can see in this picture. We should ask the patient the desired tarsal height, how much the patient wants, because many women want a larger height for beautification of the tarsal to apply eyeshadow and eye makeup. And we should avoid the incision going over the nose, and this avoids medial canthal webbing and an unhappy patient. Also, if we have xanthelasma in the upper eyelid, if the xanthelasma is small, then it can get very nicely corrected with the lid crease incision that we give for blepharoplasty. However, if the xanthelasma is very big, then we will not be able to remove the entire xanthelasma as shown in this picture, and we should tell the patient that some of the xanthelasma would remain back, and no amount of anterior lamellar shortening should be allowed. Otherwise, there will be lid lag of thalmus, all those things. Now, one technique does not fit all. Like in this patient, there is so much of fullness below the brow on the lateral side. It may be a fullness due to lacrimal gland, or after the lacrimal gland has been repositioned, a subbrow incision or subbrow blepharoplasty would have been a better option. Now, if we as I have said previously, that anterolamellar shortening should not be allowed, should not be done. And I have recently seen a patient like this, where excess amount of upper lid was removed, upper lid skin was removed, orbiculus removed, and here you see the lid lag and lag of thalamus. Now, lower lid retraction is possible in elderly people, like in the first photo. She's a 77-year-old female. After transconch blepharoplasty, in the immediate post-operative period, she developed this lower lid retraction. She had lateral canthal tendon laxity, and it resolved with massage. And as the edema went, and she did massage from down to up and resolved. Transcutaneous blepharoplasty, anterolamellar shortening can cause lid retraction, as you can see this picture. So in this patient, she came to me for lower lid retraction, and I managed it with massage and IPRF injection, and she improved to a certain extent. Now, another important thing which is easy to have in the initial years of our practice is residual fat prolapse. As you can see in this gentleman, this is the first surgery before and after. Sorry. And if there is a residual fat prolapse like this, it needs to be removed by a second surgery. So that's okay. We can do it. This is a minor, just open the conjunctiva and do it. That's all. Now, residual fat is very common in the lateral part of the lower lid because that area is tight. As Dr. Akshay says, the fat hides behind the rim. And so many times it is good to remove the lateral fat pad first. In the final step of the surgery, we should reposition the lower lid and do ballotment of the globe and see if any excess fat is there, any residual fat is there, and which has been overlooked earlier. And we should also compare the both sides if both sides are equal. Now, hemorrhage. Hemorrhage is a very frightening complication, and little bit of ecchymosis on the eyelid and in the conjunctiva is okay. But major ones should be avoided. So pre-op, we should do coagulation profile, avoid blood thinners, control the BP, and tranexamic acid injection has been a game changer recently. I use tranexamic acid IV 1 gram for my patients pre-op, and intra-op we should avoid the hitting the blood vessels. We should gently pull the fat and gently sculpt the fat, and we should ensure absolute hemostasis before closure. Now, tranexamic acid, as we all know, 1 gram IV over 10 minutes, slow IV injection helps significantly when given pre-op, helps significantly intra-op and post-op. So there are a lot of literature of blindness, but the incidence is very less of orbital hemorrhage, and it presents with sudden onset of pain and profound vision loss. And that is why we should observe every patient in the ward for at least 4 to 6 hours prior to discharge. And we should share a cell phone number where the patient can contact us in case of emergency. Vision loss, apart from hemorrhage, can also be due to optic neuropathy, due to vasospasm. There are literature where vasospasm happens due to epinephrine injection. There are reports of angle closure glaucoma in patients who are predisposed, and hypertension was noted to be the most common predisposing factor. Now, intrapupillary dilatation is a scary thing, but usually it happens because the constrictor fibers have been hit during injection. It usually is not an afferent pupillary defect, and the shape of the pupil will be oblong. And how to check it is that if we shine light on the dilated pupil, the other side pupil should constrict. If it constricts, then we are safe, nothing wrong. Now, double vision is rare, and if it happens, then if we wait it out and if we give steroids, it will resolve. Now, in the lower lid, the inferior oblique muscle is very deep. The nasal and the central fat pad hides it. It is beneath. So it is fairly safe if we do it safely. And it is more common in the upper blepharoplasty from injury to trochlea and superior oblique muscle during nasal fat pad manipulation. Now, this is the last slide where blepharoplasty, lower lid blepharoplasty after under eye filler. This is very common. We see a lot of patients now who have undergone under eye filler before. And always we should ask history of fillers prior to surgery and any history of dissolving of hyaluronidase. and the surgery becomes complicated, there will be delayed healing. And there are reports where filler induced inflammation post surgery. It works well if we give myclophenolate 250 milligrams. But however, if the patient has not given history before, but post-op, if the patient is not recovering well, then we should again ask for history of fillers few years back, at least. So to conclude, this is a very gratifying surgery. The results are dramatic, and both the surgeon and the patients are usually very happy. And we should just be mindful of a few do's and don'ts during our surgery. Thank you for patient hearing. Thank you.
Thank you very much, Dr. Mopia. Lovely talk. And I would want the experts to give their thoughts on that. Dr. Milind, Dr. Shubhra.
I think, ma'am, we have covered BLEF quite a bit. I think most of
Yeah.
it is covered. But yeah, one very important point which Mopia touched upon is the last slide, where there are a lot of patients coming post-filler for BLEF. So we don't know it is filler-related, residual filler causing an effect, or is it really a fat prolapse? So I think a judgment is needed there, and whether to dissolve that filler or remove that filler and go ahead with blepharoplasty. These are the cases which are becoming pretty challenging in our practices, rather than the virgin blepharoplasty patients who come in. So I think that's very important.
Dr. Milind?
I enjoyed Mopia's talk. Thanks, Mopia. No comments from myself.
Thank you. So we now go on to the expert of experts talk, Dr. Milind, who's going to be telling us about surprises in aesthetics. On to you.
Let me share. Okay, are you able to see the slide?
Yes.
Okay, let me see if I can load it up. All right, so my talk is about surprises in aesthetics. I think the biggest pleasant surprise for me was Lakshmi spending her time with us for 3 years. And now I'm glad that she is in Eye Foundation. While she was here, she just made sure that my journey through this difficult aesthetics practice was very comfortable.
Dr. Milind, you want to go to slideshow view? Use the slideshow. We're seeing presenter view.
Oh, is it? Let me check that. Is it better now?
Yeah.
Yeah, perfect. Okay. So I'm not really going to talk about the worst kind of surprises I got, but something which would be common, either complications or something to remember, which might come to you as a surprise when you are treating these patients. And for all of us who are injectors, particularly when we use needle, periocular bruising is one issue. And although subcutaneous bruising is more common, but occasionally you can even get subconjunctival, and that can sometimes alarm our non-ophthalmic colleagues. This won't happen unless your needle is quite deep, but it's possible sometimes, and it's important to warn patients about it. Also to check that they don't have anything socially important in the next couple of days. And whenever I see an active bleed that is coming out from the needle puncture when I withdraw my needle, although our usual reflex is to place a patch on it, I prefer to let it bleed and let coagulation take over and stop it, because I don't want that blood to collect under the skin. I would rather have it flow out and mop it off. So that's one sort of tip that you can remember. Post-Botox ptosis is very common. Here I see a more moderate to severe ptosis and a milder version. So you can have the entire spectrum of it. It's very common when one is treating the glabular region. And there is an obvious explanation to why this would happen. So when we are trying to treat the corrugator muscles, some of the drug is going to seep along the periosteum or even the veins. And you can see that the levator muscle is quite close to where we inject. So particularly in patients who have a little bit of brow ptosis, this can be a challenge. Warn this to the patients. Sometimes brimonidine eye drops might work in the postoperative period, but usually this is a frustrating period of waiting until the ptosis improves naturally. So periosteum and the veins are the proposed mechanisms for this. Whenever we inject crow's feet, as our dermatology colleague explained so well, you have to remember that the spots that we inject are very close to the lacrimal gland when we go a little higher up along the canthus. And someone who's already using dry eye medications can be tipped into a more significant component of dry eye. So just keep that in mind. Plus, the second thing which you need to remember is to make sure that your crow's feet injections in the lower eyelid are not too low. Try and stay above this line so that you do not affect the zygomaticus major muscle, which can affect your smile. Blindness, we did discuss about this. It's not only applicable to fat and fillers, but even PRP injections. And what really happens here is too many things have to go wrong. You have to be using a needle which pokes an artery, and then you're injecting very fast into an artery, which kind of goes retrograde and gets lodged into the central retinal artery. As of now, there are no good treatments available if this happens, so prevention is the only way. So if you want to shift to a cannula instead of a needle, that's proposed as a safer option. A little bit of surprises here. This is a patient came to me for dark circles. I have a cream of my own, which is called milinthione. And this is a face whitening cream. And within 6 hours, it improves your under eye dark circles. So this is a gimmick used everywhere on the internet and all the social media. What you're trying to basically do is to take a picture without a flash and then repeat the same thing with a flash. This is common. Here are examples of patients where the lighting is used to try and show a result. So this is kind of a surprise. It fools patients, but then they hit hard when they really see the results, which are not as dramatic as is shown here. So keep this in mind, that light tricks are very common on the social media. When you're planning blepharoplasty, there is a case where the eyelid and the fat bags are very obvious, but try not to miss ptosis along with it. This was a patient who also needed a ptosis surgery on the left side, apart from the blepharoplasty that we did. Another example, patients who may show excess skin in the upper eyelid might actually have a requirement of a filler or fat in the brow to just fill that and make that fold disappear. Here are other examples of patients where we are discussing blepharoplasty, and that's what the patient has come for. But you can see this bump here temporally, which is the prolapsed lacrimal gland. More common in patients with thyroid, more common in patients with blepharochalasis. So to keep that in mind, that you might have to refix the lacrimal gland in these cases. Apart from lacrimal gland, you could have medial fat pad removal, you could have a canthoplasty, and even alterations in the levator, reattachment, or even recession as add-ons. For patients who have very low brow and a skin fold which is missing, here is a patient where I did a bleph, but you can see that in the primary gaze, I don't really see a result. That was a surprise for me. So in these kind of cases where the skin is already less in vertical dimensions, you don't really need a blepharoplasty. You actually need what is called as a fold formation. So you cut the skin, but you don't excise skin, and you reattach it to the levator so that you create a fold there. Another red flag is patients who present to you with fat bags in young age, young or middle age, which probably was not there earlier. And it's important in these cases to look at their old photos. This was a patient who developed euthyroid eye disease. Her blood levels were checked every time it was normal. And this has to be kept in mind. Otherwise, we miss out on a lot of patients who are borderline thyroid. Talking about the importance of the canthus. This patient looks better, not just because we repaired her ptosis, but we also fixed her lateral canthus at a slightly higher position, and that really improves the kind of sad look that one has in her eyes. And it's a very simple step which you can add to the lateral end of your incision, whether it's ptosis or blepharoplasty. You pick up the last meibomian gland on the lower eyelid and just fix it to the lateral orbital rim. So I'll stop here. This was a mix of surprises, warnings, and even tips here and there. Thank you so much. And for those who are interested in aesthetics, we invite you for 3 days straddling the Valentine's Day next year for a meeting that is focused only on oculofacial aesthetics. Thank you so much.
Thank you so much, Dr. Milind. It was actually the best for the last. Really was a very nice talk. In fact, there was not a moment for a non-oculoplasty person like me. Every sentence, every word, I think I'll remember forever. I hope I say that tomorrow morning. Such a wonderful talk.
Thank you so much. You don't have to remember them because you have Lakshmi now.
I know, we have Lakshmi now. Yes. This was her idea that we should have this meeting. Last month, we had an oculoplasty webinar. She was so keen on this, and I'm so glad we agreed. And all of us, I'll share the entire link. Please post it everywhere because it's a very wonderful webinar. It's so gripping. I think all other ophthalmologists deserve to watch it. Thanks a lot. Lakshmi, you want to add something?
Well, I'd like to thank all the speakers. It was great. It was every talk had something different or something which even added to my knowledge. And I'm so glad, Dr. Emin, that you put good photos of me and you didn't put any unwanted photos. And it
I'll
was a
save
great
those
talk.
for the next webinar.
Yeah. Thanks, Priya, for being with us. And you told us to be cautious. Shukra, Akshay, Dr. Mopia, every single talk. It was such brilliant talks. And I missed out. Our Prerna is not here. They were not here, but they started off. Everybody's talk was too good. Like if any patient wants in Coimbatore, unless Lakshmi has picked up all of it, I know where to send my patients.
Thank you.
Thank you so much for being with
Thank
us.
you, ma'am.
Bye bye.
Thank you.
Bye bye.
Bye. Thank you. Thank you.
Thank you. Thank you,
Thank you.
everyone.
Thank you, everyone.